Hello, my name's Dr. Mary McCaffrey. I'm based in the Scotia Clinic in Tralee, and we have regular fertility meetings which are complementary to couples that are thinking of undergoing fertility investigations and care. Unfortunately, with the COVID pandemic, we have been unable to have meetings, so we are changing this over to an online forum, which hopefully will be as good. So myself and Fabian Ward, who is an embryologist and andrologist, will be talking you through the process of fertility investigations and treatment today. So I'm going to start by looking at pregnancy rates and how likely someone is to become pregnant. And we know, for example, that if you take a young couple in their early 20s, totally healthy with no major problems, what do you think the chances of them getting pregnant would be? Most people would think it's probably really high, 75% in any month that they might get pregnant. It's actually 25%. So if you think of a young healthy couple with no problems only achieving a pregnancy in 25% of cases, then you can imagine that as people get older, the problem of fertility becomes even greater. So we know from all of research that a woman's age is the most significant factor that we have to look at when looking at how likely someone is to get pregnant. So we know, for example, we've just said at 22 years of age, 25% of women are likely to achieve a pregnancy, and this goes down quite gradually until you're mid to late 30s when there's quite a significant drop. And by the time you've reached 40, the chances of becoming pregnant are between 10% and 15% and very dramatically lower after that. So trying to achieve a pregnancy when you're younger is great. Obviously, we know that that's not always achievable for people because they don't have partners. But if someone isn't becoming pregnant quite quickly in their 30s, we would always recommend that they seek advice at the earliest possible stage. So we're looking at a decline with age. 30 years of age, you have a 20% chance of becoming pregnant. And as I said, at 40, at best 10%. So let's look at what is actually the definitions for fertility. In general, the official definition of infertility is failure to conceive within 12 months of unprotected sexual intercourse. We then sometimes talk about this as primary infertility, where there's never been a pregnancy achieved, and secondary infertility, where people have had a previous pregnancy that could include a miscarriage or an ectopic pregnancy, and within 12 months. However, even though that's the official definition, we would always say to people that if you're 35, we wouldn't necessarily be waiting 12 months. At the very least, have your investigations done. You know if there is a problem and you can act on it very quickly. So the normal pregnancy process is that a woman produces an egg every month. We start at the beginning of a menstrual cycle, and gradually an egg grows over a period of time, and by day 14 the egg is ripe, the hormones are surging up, the egg is released, and if someone has intercourse around that time and the sperm meets the egg, then we know that there is a chance of a pregnancy. We know statistically that depends on the age that you are. And we can monitor a lot of these processes to see if they're working based on hormone blood tests. So that is the process of an ovulation cycle. So the egg is released from the ovary, and this is your fallopian tube. So the egg then passes down along the fallopian tube, and the sperm, if someone has had sex, will pass up into the uterus, and the sperm and egg actually meet, and if they're going to fertilize, that happens in the fallopian tube. And the fertilized egg is then wafted down the fallopian tube over a period of days to implant in the uterus. We know that sperm lasts for about 3 days in the genital tract of a female, and we know that the egg lasts for about 24 hours. So if someone is having regular sexual intercourse twice a week, there should always be sperm around the time of ovulation. And it can be a bad thing to only zone in on ovulation as the time to have sex, because if you've missed that opportunity, then you've completely missed it. Whereas by having sex twice a week, then the sperm should always be there. So that's how the process of fertilization and implantation happens. So what kind of things can stop someone getting pregnant? Well, the first thing that can happen is there may be no eggs in the ovaries, or the eggs may not be being released from the ovaries. If there's something wrong in the hormonal process, there can be eggs there, but they mightn't be released. For example, that happens in a condition called polycystic ovarian syndrome. So that is one thing that could happen, no eggs being released, or eggs may be released and there could be a blockage within the fallopian tubes and they don't get to meet the sperm. Or there may be no sperm, or the sperm may not be able to get up because there may have been surgery to the cervix in the past during, say, for example, colposcopy procedures such as Let's procedures, cone biopsies, or there may be a problem with the mucus in the cervix that it doesn't let the sperm in. Or there may be a problem within the uterus that it can't, the implanted or the fertilized embryo can't implant because the lining isn't thick enough, because there's fibroids or polyps in the lining, or the lining may be rejecting the implanted embryo. And then obviously there may not be any sperm for whatever reason. So they're all the reasons of what could possibly go wrong. We know that there is a third of cases will be due to some female factor, due to either ovulation or a problem with the womb and tubes. A third of cases may be male factor due to either no sperm or an inadequate number of sperm or not good quality sperm. And in a third of cases, there may be unexplained or two processes happening. So when a couple come to us and they want to be investigated as to why they're not getting pregnant, we have a core number of tests that we do. And because we know, as I've said, a third of women, a third of men, we don't tend to zone in on one rather than the other. We tend to move forward with our investigations quite quickly because it's important not to lose time. So a semen analysis is one of the tests that we do, where we look at sperm counts and the percentage of sperm moving. And I know that Fabian's going to talk a little bit about that later, so I'm going to leave that for him. So when we look at women, what tests do we do? The first thing we want to know is that there are eggs. And there's a hormone test that's the most common test nowadays called anti-Mullerian hormone. And that's a marker of whether there are a sufficient number of eggs in the ovary. So we would do that blood test, very, very common test and a very important test because we need to know that there are eggs. We often supplement that test with a transvaginal ultrasound where we look at the ovaries on scan to look at what we call an antral follicle count, AFC, where we predict is there an adequate number of follicles there for someone to become pregnant. Obviously, if the AMH or the antral follicle count is very low, then that would be a warning that we need not to delay on trying to proceed with getting pregnant. And it might be that we would bypass very initial treatments like tablets like clomiphene, Femara, and move to IVF very quickly. So that AMH test is very important. And we know from this graph here, which you can look at in more detail, that the AMH goes down as you get older, and that fits in with what I said earlier, that female fertility reduces as people get older. So you can get your we get a number when we get the blood test result back, and we can graph it for someone's age and predict, are they in a safe zone, the green zone, or do they need to move a little bit more promptly towards treatment. So that's one of the tests that we do. We also do blood tests for thyroid function, prolactin. We look at your progesterone in the second half of your cycle to see did you ovulate in that cycle. And the ultrasound scan is important as well. And we talked earlier about abnormalities in the womb and the fallopian tubes. There's 3 tests that we can do. We can do a laparoscopy and dye test, which is done under anesthesia, where you come in and you're put to sleep and we put a camera in through the belly button and we look at the fallopian tubes and the womb, and we look at whether the dye passes down along the tubes. So it involves an anesthetic and it involves an operation. It's not without its risks. Then on the other hand, there's a test called an HSG, a hysterosalpingogram, which is an x-ray where we put dye in and do an x-ray to see, can we see the dye going down along the tubes. Really, that just tells you about the tubes. Are they blocked or are they not blocked? You don't get to see the ovaries and you don't get to see the rest of the womb. So the test that would be the most common one that we would prefer to do most for people is an SIS or hysterosalpingosonogram, and that's an ultrasound scan that's done with dye, so we can do the scan and watch the dye. It's very dynamic, it's a fabulous test, and we can look at the dye going down the tubes, but at the same time we see the ovaries. We get to do the antral follicle count, we get to see if there's any fibroids in the womb, and we get to see if there's any abnormal shapes in the womb. And nowadays we would most of the time do this as a 3D ultrasound, because that would be the gold standard. So we would rarely do laparoscopy and dye tests now if we have access to a hysterosalpingo-sonogram. So that would be another important test to do. Sometimes we do something called a hysteroscopy, where we look inside of the womb with a camera and we can see the shape of the womb on the inside. Again, that very specifically tells us about the womb, but it doesn't tell us about the outer layers of the womb. So I tend to only do that if I found something abnormal on the hysterosalpingo-sonogram, and then you're proceeding to deal with something that you know is abnormal. We know that lifestyle is really important, and this is one of the cornerstones of when people come to us for a consultation or they do an online consultation with us. We look to see if people are smokers. And nowadays we would include vaping in that, recreational drugs in that. We would look at alcohol intake for both men and women, very, very important. We look at exposure to chemicals, environmental hazards, and weight and diet as well, because having a low carb healthy diet is really, really important, particularly for women, particularly if they could have polycystic ovarian syndrome. And polycystic ovarian syndrome is associated with an imbalance of hormones and an intolerance to insulin. So that would be really important. And stress as well, very important. We now have an online mindfulness program for our fertility couples, which you can access through the clinic if you want to ring us. So what kind of treatments can we offer people? If everything is okay and a couple are young, so if I saw this 22-year-old couple and they had their investigations and everything was normal, I think it wouldn't be unreasonable to say try again for a further year. And if you're not pregnant at the end of the year, then we would reassess the situation. Sometimes people do a treatment called IUI, intrauterine insemination. And that's where we take the best of the sperm in the middle of the month and put inside the womb. It can be useful for people maybe where intercourse isn't very frequent, maybe their partner's away a lot, maybe there's sexual problems that can't be addressed, or if there had been surgery to the cervix that we can't really explain why the sperm aren't getting in. But if something is wrong, we will move on to more in-depth forms of treatment, and nowadays we probably recommend IVF more so than we ever did in the past. And with IVF, the younger you are doing it, the higher the pregnancy rate. So for example, in a woman in her early 30s where there was no majorly significant issue other than maybe they're just not producing the right number of eggs or whatever, you would have a 40 to 60% chance of a pregnancy, and that goes down as you get older. But Fabian's going to talk a lot more about the lab side of things and explain what's involved in that. So when a couple starts with us who need IVF, the first thing we need to do is work with them to figure out what's the best clinic for them to go to. And everyone knows there are a lot of IVF clinics within our country and abroad. Different clinics have different expertises, and it might be there's something very specific needed for a couple. They might need something called PGS, which is genetically screening embryos, and we would find the clinic that has the best expertise with that. Or there might be clinics that do surrogacy or egg donor or whatever. And we also have to bear in mind that when a couple are picking a clinic, finances may come into it for them. So they may be looking at picking a clinic that financially works better for them, and we would have to look at that option for them as well. Some people like to go abroad, other people prefer to stay at home. It all depends on their personal circumstances. And we have a number of clinics that we work with, and we would help a couple to pick that clinic. Then the majority of clinics that we work with, and I think this will become an even bigger issue in the future after the pandemic, most of our clinics now will do Skype consults, Zoom consults with patients and couples, so that they get to meet the clinic that they will be having their IVF in, but they do the consultation on the phone, the care plan is planned on the phone, and their drug regime is planned, and we write the prescriptions. So when they start their treatment, they can stay in Kerry for the most of it. So they have their scans done with us, their blood tests done with us, and hopefully when they become pregnant with us in the future, then they have their pregnancy scans here. So if they're doing what we call shared care IVF or satellite IVF, they have only 2 visits to the sister clinic or the mother clinic, and that is the egg collection and egg retrieval, and then for putting the embryos back. So that would be the system that we work for most of our patients. So when people are starting on an IVF cycle, our aim is to try and get a large number of eggs from the female. So she goes on injections, which she takes every day, which would be quite a high amount of hormones in them. And then people are scanned after about 6 days on their injections to see how well they're responding. We're checking the number of eggs that are growing, we're checking that the lining of the womb is developing, and we do blood tests to see that the hormones are behaving like we expect. And if all is going according to plan, then they stay on their injections, and another scan is repeated 4 or 5 days later. Usually from that scan, the date of the egg collection can be planned from there. You can never plan everything to a fine art. There has to be a degree of flexibility, and when couples are starting out, they need to know that they may not be able to rigidly know that they will have Friday, Saturday or Sunday as the days they need off. They need a little bit of flexibility. And those scans that are done here, we then send off the results to their mother clinic, who then plan going forward from there. So that's how that stage of the IVF cycle happens. So the oocyte retrieval or egg collection is done under sedation, and it's a transvaginal scanning procedure where a very fine needle is passed in through the vagina into the ovaries, and the eggs are removed from the ovaries and handed to Fabian or a Fabian colleague in whatever lab, and they look after the eggs from there. The procedure is done under sedation. It takes about half an hour, and most people will be gone home from their clinic within 2 hours. Then the following day, the embryos are assessed in the lab for fertilization, and they're looked after by the embryology lab, who decide if there's going to be an embryo transfer and when it's going to be. And then there's a 2-week wait after the embryo transfer. People are on medications to enhance the lining of the womb, to enhance the chances of a pregnancy. At the end of 2 weeks, a pregnancy test is done, and then all of us are there with fingers crossed, praying for a positive pregnancy test. And if a positive pregnancy test happens, then the woman will have a scan done about 2 to 3 weeks later to assess the pregnancy. I'm going to talk a little bit about social egg freezing, because I think more and more people are going to be aware of it. We talked earlier about a woman's egg count, AMH, antral follicle count, all being at its best up to the age of 35. Lots of people don't have partners to have babies with when they're in their 30s, and more as techniques have improved in our labs, social egg freezing is possible, but equally egg freezing may be necessary because someone has a history of a condition called endometriosis. They might be going to have cancer treatment, they might be going to have surgery that will interfere with the eggs. And now with techniques in labs, egg freezing is a feasible option for some women. I would say to people, the time to freeze your eggs is when you're younger, because if you wait until you're older and in your late 30s, early 40s, the chances of getting a large number of good quality eggs is much, much less. So I've explained the clinical and medical side of the IVF process to you. So when we produce eggs and we give them to our embryologist in the lab, they then take over the care of those embryos. So I'm going to let Fabian explain to you what happens, the eggs and the sperm, when they arrive into his lab on the morning of your oocyte retrieval.
Thank you, Dr. McCaffrey. My name is Fabian Ward, and I'm a senior embryologist, and I've been doing embryology for the last 15 plus years. So what I intend to go through is a brief introduction to what you can expect from an embryology laboratory, from egg recovery through the first 6 days of the growth of that embryo, and the potential transfer of that embryo, or potentially freeze an embryo if it's suitable for freezing. So the EU Tissue and Cell Directive was introduced into Ireland in 2007 and it's implemented by the Health Products Regulatory Authority in Ireland. So they regularly inspect all clinics on a minimum of a 2-year basis, and the things that they are looking for are the things that we would expect to find in a good quality embryology lab. So we can be confident that all labs in Europe are at this standard, albeit different countries inspect to different levels. Ireland does inspect to one of the highest levels and standards that are applicable. So within an IVF laboratory, most of the work is done under a laminar flow cabinet. So embryos and sperm are much too small to be seen with the naked eye, so all that work needs to be done under a microscope. So that microscope is in a controlled environment where the heated stage underneath it keeps your eggs, sperm or embryos at a consistent temperature. So what you might expect to find within a laboratory would be things like a laminar flow hood where most of the embryology work takes place. So eggs, sperm, embryos are much too small to be seen by the naked eye. So all that work has to be done under a light microscope. So that light microscope is located within a laminar air flow hood. And that means that it's a very controlled environment where both the temperature is controlled and the amount of particles that are allowed in the air is also controlled. Most standard incubators would be box incubators where the sperm, eggs and embryos are maintained at a constant environment. So that matches our body temperature where we are at 37 degrees. So it'll be plus or minus half a degree. The slight difference would be that the oxygen and the carbon dioxide are kept at 5 to 6%, and this mimics more closely the uterine environment that an egg would expect to be released following ovulation, or the sperm would be expected to traverse following insemination. Some of the more advanced incubators use time-lapse, and we have seen that become much more popular across all clinics over the last number of years. It's something that makes our job as embryologists much easier. It means that instead of opening an incubator and taking it out and looking at it under that stereo microscope, the embryos are examined, or an image is taken of each one of them every 5 to 10 minutes, and it's compiled by software, and we can view that software and look at each embryo without taking it out of that controlled environment. Again, something that every single laboratory has are dewars containing liquid nitrogen that are used to preserve your surplus embryos if they're suitable for freezing. And it's also a very useful technique for freezing eggs for social freezing, or in cases where we may not have been able to recover sperm during an egg retrieval, and for any number of reasons. But under liquid nitrogen, your eggs, sperm and embryos can be maintained for decades without any effects that we are aware of that would see any deterioration in them. So all of that equipment, the better the equipment, the better the quality of the laboratory, but with the EU Tissue and Cell Directive, the standard of equipment across all laboratories has increased over the last 10, 12, 15 years. But what is most important is how it's monitored and how it is maintained. So I would be insisting, and it is a part of the directive, that all of the equipment that you've seen would be monitored by a system that would text the user during out of hours to alert them to an event that may have occurred with the equipment. So where an incubator would fail, or where maybe a door may be left ajar, the operator knows within a few minutes that the temperature has dropped and that there is a problem. So that system is not dependent on a person being in the laboratory physically looking at the equipment all the time. So every clinic has some sort of SMS or some sort of alert system attached to all their equipment, so that they're aware at all times that the equipment that they've got your sperm embryos in is operating at the correct temperature and at the correct oxygen and carbon dioxide environment. And the same also goes for the dewars that your frozen sperm or frozen embryos are in. They are filled with liquid nitrogen. If something was to happen with that, the temperature would change from minus 196 quite quickly, and that is picked up very quickly by the monitoring equipment, so that we're aware that there may be an issue with some equipment. One of the other things that is not necessarily a requirement of the EU and Tissue and Cell Directive, but It's certainly a requirement in most labs now, is some sort of electronic witnessing, as well as the mandatory double witnessing that occurs when we move sperm or embryos from one container to another. So the electronic witnessing works quite simply by having some sort of a tag device on each container. It is allocated to your details and your details only. So only your gametes can be on the heated stage or in that work environment that's been monitored at any one time. So once you're paired with your partner, the sperm is allowed to come into that work area with the embryos. But if you've not been paired, it will cause what's known as a mismatch, or if somebody else brings out a container that contains eggs or embryos belonging to a different patient, it's like a radar system and it picks up on that immediately and alerts the user. So it works before there's a chance for a second manual double witness, which is mandatory to come in and check. But if that type of event does occur, you must input a reason for the mismatch, and you must also get a second person or your lab manager or somebody more senior to come in to verify that it's safe to go ahead with the procedure that you're currently doing. So here, the electronic witnessing constantly monitors the work area under the microscope. So it's able to pick up any dishes that are left in the area as long as they have a tag on them, and anything that contains a sperm or an embryo or an egg will be tagged with your details. So this embryologist left an empty container out belonging to a different patient. When they brought out the next dish for a different patient, it causes the system to create a mismatch, and that must be followed up by putting in data to say why it has occurred. And these types of events, these non-conformances, are auditable by the HPRA, our regulating body. They will look through them and they will scrutinise every single one of them to make sure that the correct follow-up action was taken any time this may have occurred. So that kind of moves us on from the standards that we should expect and do expect of any laboratory that we would be considering using for IVF or ICSI. Routinely, we would expect a male to have about 200 million sperm in the ejaculate. Those 200 million sperm are quite quickly whittled down if you're trying to achieve pregnancy naturally, as many of them will be lost in the vagina. Quite a small proportion will get through the cervix, and by the time we get to the fallopian tubes and the site of ovulation, there may be only dozens of sperm left. Now, in some cases, a male may have only a very small number of sperm available in the ejaculate, or maybe no visible sperm. And in those cases, we would routinely do a number of tests to establish if the correct hormones are there at the correct levels, so that we know that there is the potential for sperm production. And if we can get the data to show that sperm production is possible, we quite often would do a biopsy procedures on the testicles where we extract the sperm, and we usually would freeze it for later use rather than do it on the day of an egg retrieval. And these TZ procedures are quite common. I would say we would do them in about 3 to 5% of cycles and may require TZ sperm. Now, there is a risk with TZ. Sometimes they will only be exploratory, because in about 30% of all TZ procedures, we would not recover usable sperm. But we can judge that and be able to counsel you much better once we would have hormone test results back and potentially scrotal examination done by a urologist, so that we can gauge what are the chances of achieving sperm through that process without having to put you through it first. From there, I'm just going to briefly go through what is involved in each of the processes that Dr. McCaffrey has already described. So we're talking about IVF, ICSI and IMSI. Okay, so in a normal sperm sample, we would routinely expect there to be about 200 million sperm, which is much more than adequate when you consider that we only need that one sperm for the one normally ovulated egg per month. But during the course of natural fertilization, tens and tens of thousands, if not millions, of those sperm take the wrong route. They get lost. They are going into an environment that is hostile to them. And it's actually only during ovulation that the cervix opens up enough to let a small number or fraction of that sperm through. So after those small number of sperm have traversed the cervix, many of them do get lost in the cavities and the crypts within that, and they are trying to get as far as the site of ovulation. So they still have to get through the uterus, they still have to get all the way up the fallopian tube, and no matter how many have got into the uterus, half of them are going to take the wrong route and take the side that hasn't ovulated. So after starting with those hundreds of millions of sperm, it wouldn't be uncommon for less than 100 to reach the site of ovulation. So once the sperm are swimming up the oviduct, there are small cilia on the oviduct that help that sperm's journey up, and it also produces a current that means that only the fittest sperm and the sperm that are most capable of swimming are able to get there. So swimming against that current that's created by the cilia, it is a form of natural selection, and the sperm that gets there first still has quite a bit of work to do. So once it reaches the egg, it goes through that cumulus oocyte complex, which are the cells that are surrounding the egg. It burrows through them and reaches the top of the egg itself. The first one to get there will fuse with that egg membrane, and there's a chemical process that happens that allows that activated sperm to release certain chemicals that will prohibit all other sperm from entering. And it would only be very, very occasionally that a second sperm would be able to enter at the same time, and that would result in abnormal fertilization and an embryo that's not capable of achieving a pregnancy. So this process that we are describing here, this is what happens naturally, and that sperm has got into the egg cell. This is what we expect to happen during IVF. The only difference is that we are harvesting more eggs. So instead of that one egg that is routinely ovulated every month, we would hope to get between maybe 8 and 10 eggs, but we are much better able to gauge that once we have your hormone test results, and we can see how many eggs that we would be expecting to get for your particular circumstances. So when we have more than one egg, we're doing better than the one that is ovulated naturally. So with IVF, we also prepare the sperm so that we are selecting the best fraction of those sperm and adding them to the dish to try and achieve fertilization. And with IVF, fertilization happens as naturally as it does with natural fertilization. That sperm is still competing and trying to compete to get to that egg. So once that sperm cell has got into the egg, the DNA within that head, which we've talked about for DNA fragmentation, it starts to decondense and completely separate, and it's that DNA that contains the chromosomes. So you get the 23 pairs of chromosomes that separate. 23 will be from the sperm, the other 23 from the egg. They will form the pronuclei that we will see later on. And it's the fusion of those two pronuclei, one from the egg and one from the sperm. It's that fusion that creates the unique genetic individual that will result in the embryo, hopefully, that will go on to implant. So this video very eloquently describes and allows us to visualize that process. And there are hundreds and thousands of combinations of those chromosomes that give rise to us all being individuals. Even identical twins, while they may be genetically the same, there's a microenvironment that those eggs are and embryos are growing in that may be contributing to their unique genetic identity. Right. Another method of achieving fertilization is using ICSI, intracytoplasmic sperm injection, where we select an individual sperm and it is directly injected into an egg. So that's sperm selection. We have a short video just to show you how that happens and how the process of injecting it into the sperm takes place. Okay, the ICSI process is a little different to the IVF that we've just described. With ICSI, we are selecting an individual sperm. So here you can see the embryologist is just cutting the tail of the sperm, and they're just cutting it enough to allow the DNA within it to be available to the egg once it's injected. So here the mature egg is lined up on the ICSI rig. You can see the polar body that indicates it's mature at the 12 o'clock position. And the sperm is injected through the egg at approximately the 3 o'clock position. So the sperm will enter the egg cell head first, and it's very important that the membrane of the egg cell itself is broken during this process, and that's to allow the interaction of that egg cell and the DNA within with the DNA that's going to be introduced by the sperm via the broken tail in the sperm. So the embryologist injects through the cell and then pulls some of that membrane back to allow it to break it. And once it's broken, they can push that individual sperm cell directly into the egg. And once that has happened, the egg is released from the holding pipette and the embryo or presumptive embryo is put into culture for the next 18 to 20 hours, and it's only after that that we are able to see if normal fertilization has occurred. So for a short time after the injection you can see the indentation that the needle has made, but that quite quickly will disappear. And if you look at that in 5 or 10 minutes after the injection, it will not be visible, but it is a very useful indicator when you're looking at the eggs to see which ones have already been injected. So routinely it takes about 2 minutes to do one egg for ICSI, and the IMSI procedure that we will describe takes considerably longer because we're putting much more emphasis on the sperm selection, and it can take up to 15 minutes per egg to find suitable sperm. So another technique that can be used to successfully fertilize eggs is IMSI, or intracytoplasmic morphologically selected sperm injection. It's effectively very high magnification selection of the sperm. Normally when we're selecting sperm for the ICSI process, the magnification is at about 200 to 400 times, and we can see that the sperm are there, we can see that they're alive and that they're roughly the shape that we want them to be. But the best analogy that I've had is that if you're standing at the top of the Eiffel Tower, you can see people moving at the bottom, so you know they're alive. But to really get to see how fit they are, you need to be on the bottom floor and be able to see them. So that is effectively what IMSI can do for sperm selection. So at 4,000 to 6,000 times magnification, you can see the detail in the morphology of the head of every individual sperm. And when we get into that detail, we find that only about 1% of those sperm are morphologically what we would consider normal. So that would mean that their DNA should be quite tightly packed, that the DNA fragmentation that we talked about earlier is not a major issue, and they would be the most suitable sperm to achieve normal fertilization and achieve an ongoing healthy pregnancy. Now, we don't recommend that IMSI is for everyone because quite obviously the IVF and ICSI techniques work very well for the vast majority of patients. But for some patients where DNA fragmentation is considerably high, or where they have had a number of cycles with recurrent miscarriage, they are the cases where we would feel that it may be of benefit to those patients. So less than 1% of those normal sperm are taken out of the sample at that very high magnification using an ICSI needle. And the operator then proceeds to inject the available eggs with those morphologically selected sperm as they would routinely do for ICSI. So there's no more risk for the egg than for routine ICSI. It's pretty much a sperm selection technique. So sperm DNA fragmentation is a measure of how tightly compacted the sperm DNA is in the head of the sperm. So it's effectively like looking at if you were to open up a golf ball and look inside it, that's really, really well packed. But if that starts to fray or decondense, the fertilization tends not to be as good, and more importantly, it has resulted in, or has been shown to result in, more miscarriages. So there are a number of different ways of looking at the DNA fragmentation in sperm, but from the patient's point of view, it's a matter of providing a sperm sample. The sample is snap frozen and sent to a laboratory for analysis. And various things have been shown to affect the quality of the sperm or the quality of the DNA in the sperm, and lifestyle factors can have a very significant impact on the degree of DNA fragmentation. So it's expressed as a percentage. So in general, anything lower than 20% is considered normal, and anything between 20 and 30%, we would routinely see that ICSI would be the most suitable treatment. And over 30%, we would first look at lifestyle factors to see if there's anything that could be addressed to bring that DNA fragmentation down without having to make any further intervention. Because there are some studies that show that testicular recovered sperm have lower DNA fragmentation and can be more suitable for use in patients where we can't address the DNA fragmentation through lifestyle changes alone. So now we've achieved sperm selection from either for IVF, where we do routine sperm prep, for ICSI, where we select sperm at 200 to 400 times magnification, or with IMSI, where we've used a magnification of up to 6,000 to select the sperm. So once we achieve fertilization, what do we expect to happen in the laboratory, and when do we expect these things to happen? So early embryo development is effectively development from day 0 up to day 5, potentially day 6. So on day 0, when we recover your egg, what we expect of a good quality egg is that it's mature and that it's capable of being fertilized. So a mature egg has a polar body, which indicates that it's pushed out half of the chromosomes, effectively making space for the genetic material that's going to be introduced by the sperm. So on day 1, we can see fertilization. If it's normal, we see 2 pronuclei within that egg structure. One has come from the egg, the other has come from the sperm. When we see 2 there, we're confident and happy that the egg has done what it should to achieve that normal fertilization. If there's only 1 there, we don't consider it normally fertilized. If there are 3 there, we usually suspect that maybe 2 sperm have got in instead of the 1 that we routinely expect to see. However, that normally fertilized egg or embryo that I see, I can't tell how we got to that point, whether it was IVF or ICSI or IMSI, without looking back at the lab notes. So late on day 1, the day following your egg retrieval, we'd expect that normally fertilized embryo to divide to a 2 cell. We expect on day 2 that it will have divided again, so we're getting up to 4 cell. And on day 3 that embryo should be approximately 8 cells. So somewhere between about 6 and 10 cells on day 3. So some clinics do transfer embryos at this stage where they're day 3 embryos up to 8 to 10 cells. Most clinics these days will culture the embryos out to blastocyst, because at that point we know the embryo that gets to blastocyst has better potential to establish a pregnancy. Now, biopsy of embryos is something that occurs as well. And biopsy is a very useful technique. It's pre-implantation genetic diagnosis. And a biopsy of those trophectoderm cells takes place on day 5 or day 6 once those cell types are visible. But at that point, the embryos are lasered. There's a biopsy taken of those cells. It's frozen and sent off for analysis. And the embryo is put into storage, as we discussed earlier. So those stored embryos are labelled, and when the result comes back, then the embryo is either going to be genetically normal, or it will come back with a query on some of the genetics within it. This is particularly useful for patients with a known genetic disorder, but more and more of the genetic programs available are able to do quite a broad screen and indicate which of your embryos are chromosomally normal versus those that aren't. So it's something that, again, is not useful for absolutely everybody, but there are a certain portion of patients that may have had a number of failed cycles, a number of miscarriages, or again a known genetic disorder in their family that they don't want to pass on to any of their children. So for those, it's absolutely the right route to take. So blastocyst formation is the stage that happens after day 3, and we looked earlier at the technology that allows us to look at time lapse, and this is just a very short video that shows us what happens embryos over that first 6 days. So every 2 hours here of actual development is condensed into 1 second of video. So you can quite clearly see in some of them the 2 pronuclei. They've gone from 2 cell to 4 cell. They'll shortly go to 8 cell. And this technology also exploits the fact that we expect the embryos to get to particular stages at exact times, and it's this that helps us to select embryos. It's effectively like watching a film instead of just looking at a photograph. So it makes our job much easier, and a lot of it is about deselecting embryos of poor quality rather than selecting the really good ones. Because no matter what way we do it, if we look at a photograph at the end and we've got a really good quality embryo, the chances are it was always really good. So where the embryos have gone from the wells here, they've either been transferred or frozen, and the ones that are remaining were cultured to day 6. And a number of these are also suitable for freezing as well. So there's 2 there suitable for freezing, and there's 4 there that are not suitable for freezing or for transfer. So we did not continue culturing those, and they would have been discarded after day 6. So embryos have to get out of that shell-like culture as well. So when they become blastocysts, you could see that that shell was getting thinner and thinner. And this is just a very short clip of an embryo that hatches from that structure, and that's exactly what it would need to do after it is transferred, so that it settles into your endometrium and starts to attach. So again, at the very start you could see the 2 pronuclei. It's gone from 2 cell to 4 cell. This one's a little quicker. Every second equates to 4 hours of development. And the embryos that you see in these videos were donated for research by patients that no longer wish to keep them, or in the case of this hatching embryo, it was a not normally fertilized embryo that was actually just used to validate a piece of equipment. So once that embryo is hatched, you could clearly see the 2 cell types within it, the trophectoderm, which are these outer cells, and the inner cell mass. They will go on to form hopefully the fetus and the placental membranes. There are options for patients across the vast majority of clinics now for both donor sperm and donor eggs. Donor sperm in Europe is predominantly sourced out of Cryos in Denmark, but there are clinics with different cryobanks available. And again, a lot of clinics will have donor egg programs specific to their own clinic, where they may import eggs that are already frozen, or they may ship out sperm, and that sperm is used to fertilize the donated eggs in a third country, and the created embryos are then shipped back to Ireland. So there are various options available for all patients, but most people do use their own eggs and sperm, but there's always another route that can be taken if that isn't working after a number of unsuccessful attempts. So what is the take-home message from these presentations? Effectively, fertilization in humans isn't quite as good as we think it is. It's about 25%. The sooner that we realise that there are fertility issues, we should be looking for advice and treatment, and the sooner that this is done, the better the outcomes tend to be. And treatment is about increasing the chances of getting pregnant and having a live birth. There is always a chance that you may conceive naturally, and everything that we are doing is tailored to increase those chances to give you the best possible chance of that live birth. And again, we need to consider both the male and the female to see if there's any obstacles that we can address and maybe change, so that we are giving you that chance of achieving the pregnancy.